Bismillah ar-Rahman ar-Rahim. I hope my voice is clear.
Yes.
Okay. Assalamu alaikum rahmatullah. Thanks for for this our great group for began this webinar today. It is my pleasure to be the a moderator for this scientific activities today, which prepared by the Saudi German hospital groups. Our groups very act for regarding this the sharing and continues the activities and bring the good and very excellent speakers from worldwide. Tonight we will. It is my pleasure also to welcome Prof. Mario, Mario Antonio. It is he's chief of gynecology oncology in the hospital of Robert Suzanne in France, and will be sharing with us the surgical treatment of the endometrial cancer in a fragile patient, which is an elderly and morbid obese patient. Also, I would welcome other speaker, other panelist doctors from the Saudi German hospital groups, Dr. Ayman Zaghloul from Riyadh, which is the OB/GYN consultant and the head of obstetric and gynecology there. And also Dr. Mustafa Kamal, specialist OB/GYN from Cairo. Also, Dr. Sharda, which consultant of OB/GYN and the head of OB/GYN department from Dubai. And unfortunately, tonight she's sick and she can't attend with us. So we hope she will get better soon. And also, Dr. Mario, he will have very interesting experience for starting the subject today. So, welcome, Dr. Mario, and you can start, please. Also, sorry, after that, if you have any question, we will interaction after Dr. Mario is finished, inshallah. Dr. Mario, can you start, please?
Yes, thank you very much for your presentation. Thank you to the distinct chairman and panelists and colleagues. And thank you to the audience. I am Mario Condru. I'm professor and in Metz, France, and also formerly senior honorary senior clinical lecturer at the University of Edinburgh. This professor with the German in Egypt and Saudi Arabia. So thank you for having me. My topics tonight is surgical treatment of endometrial cancer in fragile, notably elderly and obese patients. So I would like to start immediately by saying what is endometrial cancer in terms of surgery. Surgery for endometrial cancer has always been seen some quite simple, maybe the simple surgery involving the uterus of cancers. In reality, the last 10 years demonstrated that this is a cancer that can be subtle and can be really difficult to beat. This because, first of all, it involves knowing exactly the anatomy you are having to on the other side. All the advance of technology and imaging showed us that the disease is sometimes a little bit more difficult to understand and to circumscribe. So as you can understand, as any other cancer in the genital area, there is a staging procedure that we have to undergo. And this involves preoperative preoperative imaging and assessment, and also postoperative and intraoperative conduction. So being clear that the women with abnormal bleeding in peri and postmenopausal are the ones that are mostly suspicious for this kind of cancer, we have to remind that there is a 10% of this cancer presenting before menopause in an age which is not typical of that disease. Instead, for the great majority, this involves patients who are normally well in the menopause time and are quite aged, and because of that, they bring with them a lot of comorbidities. On the other side, this is a disease that can be quite easily associated with obesity. More than 50% of the cases are associated with obesity, and this trend is going on and increasing in time. So if we talk about preoperative assessment, of course, MRI is, I think everyone will agree with that, the mainstay of the preoperative assessment today. Of course, once we have recognized the tumor and we have studied the possible involvement of the tumor, we are going to go for an operation that will involve, most of the time, total hysterectomy, bilateral salpingo-oophorectomy, the removal of uterus, cervix, tubes, and ovaries altogether, with or without lymph node dissection. This is because there are classes of risk in which we can recognize a high risk and a low risk in this disease. The low risk is a disease which is associated with a low grade of tumor and with less than the first half of myometrium, which is one of the layers of the uterus. And this is, of course, the simplest of the situation. A situation a little bit different is when we have to deal with a high-grade disease and a situation of involvement of the muscle, which is a little bit more than 50%. This, of course, is an advanced stage. And the stage can be more advanced if we have an involvement of the cervix or if we have an involvement of the ovary. Lymph node status is associated with a worse disease and must be always assessed when you're dealing with the high-grade tumor. Now, in this figure here, I can show you what are the areas that we have to assess. And because of this, we understand that such a surgery can be a little bit tricky in a person who is overweight or aged. Of course, the latest development of technology with advance in sentinel node detection are giving us a little bit of help in this in order to decrease the number of patients that we are sending for a very radical procedure. This said, this is a typical case of uterus which is involved by the tumor in a way which is more than 50% of its outer layer. And for this reason, we have to understand what is the delicacy of the situation and how much we have to pay attention, not disseminating the disease in the cavity. But let's go back a little bit to the statistics and remember that endometrial cancer not only is this kind of cancer that I showed you before, it is also the fourth most common cancer in women and accounting for around 5% of all female cancers, which means that we are facing really big numbers in terms of patients to be treated. So the incidence peak is between the ages of 60 and 79. This, of course, is related to my experience in UK. And the age range within which the largest increase have occurred, with rates doubling since 1975, and this is exactly what I was saying before, rising from 40 to over 75 in every 100,000 women in 2007. And today, we are getting really numbers which are a little bit more than that. Why is this disease relevant for the discussion of today? Well, obesity is an increasing phenomenon all over the developed world. And this means that we are going to face more and more surgeries which are related or associated with obesity. With an increasing age and obesity rates in the world's population, there is an anticipated concomitant increase in older women with endometrial cancer. And this, of course, is a natural phenomenon. And with the advanced age, the treatment of gynecology cancer often is jeopardized in fragile patients. It means that not only this was true a few months ago, today with the COVID era, we are facing more and more of these problems. Increasing rates of endometrial cancer in obese and or elderly women are something that we are seeing more and more often, with patients that are not only aged more than 75-year-old, but they are also severely obese. My experience in UK was with at least 60% of the population of Scotland, who was affected by endometrial cancer, presented to the first appointment with a BMI that was more than 42. Increasing rates of endometrial cancer not only are associated with more of those comorbidities, but this phenomenon brings also an increased risk of overall complications due to endometrial cancer treatment in this kind of patients. And more, we are going to see obese and morbidly obese patients. So the consideration is that today we have to face that obesity is now affecting 25% of adults in UK. And this is true also for France. And this predisposes women to endometrial cancer as well as other cancers. The impact of obesity on overall survival of endometrial cancer is controversial, in terms that while obesity seems a determinant in increasing endometrial cancer incidence, it is also associated with less aggressive forms of this tumor. And this is also a true phenomenon. But we have to remind that obesity is predominantly associated with type 1 endometrioid, rather than type 2 non-endometrioid, such as serous or carcinosarcoma endometrial cancer. But both subtypes, so even the type 2, are increased with obesity. So it's not always good news. The impact of obesity on perioperative outcomes represent a major challenge given the higher propensity of collecting comorbidity. And this is a little bit the problem. We are facing a tumor that has two phases. Those two phases are increased by a phenotypic condition like obesity, and they are increased by also the age, as naturally occurs with all tumors. And all this is facing, of course, the contraposition of the treatment that was, until 10 years ago, the standard treatment, which was historically a total abdominal hysterectomy and bilateral salpingo-oophorectomy. And that was more or less what was done. And this was done sometimes also vaginally. Today, we can say that this is not enough, okay? So preoperative assessment of endometrial cancer may be problematic in obese women, so that we are not always sure that what we are looking is a very simple cancer. Sometimes we are facing tumors that are demonstrating their virulence, their aggressivity, just once we are operating on. A BMI of 30 kilos per square meters indicates obesity. and is associated with an increased risk of perioperative complication just by it. While a BMI of more than 40 kilogram per square meters is described as a morbid obesity and is associated with even higher rates of complication. So this is the complication on the complication. And the obese and morbidly obese patients are therefore likely to require more detailed preparative assessment to reduce the sequelae of coexisting morbidity and more intensive postoperative care. And this is why we are seeing in tertiary center more and more interest in the capacity that we can express in reassessing those complex and more common situations that are faced by encountering obese and older women affected by this disease. So the laparoscopic hysterectomy and bilateral salpingo-oophorectomy has been demonstrated to be the surgical technique of choice for women with endometrial cancer in 3 large randomized controlled trials. And this has been introduced as a means of finding a gold standard that would be a good way to address a quite common operation with an advantage in being able also to retrieve lymph nodes without affecting too much the morbidity of the overall treatment. And 3 studies are the main, I would say, mainstay in this kind of situation. The first one is the American randomized controlled trial from the GOG, the Gynecologic Oncology Group. This was the LAP2 study, where all women underwent pelvic and para-aortic lymphadenectomy at the time of hysterectomy and bilateral salpingo-oophorectomy. Then there was another study, which was Australian and joined with New Zealand and Hong Kong, which was a randomized controlled trial in which women could be excluded for lymph node staging if they were obese or had early stage disease or were medically unfit. And in this study, 52% had lymphadenectomy. And then there is a Dutch randomized controlled trial in which women had only hysterectomy and bilateral salpingo-oophorectomy. So let's try to compare these results. In the GOG study, 26.5% of women with a BMI between 34-35 kilo square meters were converted to open procedure, and 57.1% of women with a BMI greater than 40 kilo per square meters were also converted to open surgery versus a conversion rates that normally in thin patients would have been 17.5%. So from this study, we understand that this surgery, which should be quite easy and doable as much as a standard procedure, was not so easy, with, in the American study, a rate of conversion which was quite high. And in the Dutch study, a BMI over 35 kilo per square meters was associated with a conversion rate of 32.3% versus conversion rates in thin patients of 6.5%. But in this study, there were no lymphadenectomy included. In the Australian case, the conversion rate was low for all procedures at 3.6% and not reported in relation to BMI. And this study has some kind of appeal, I would say, but on the other side seems to have been a bit flawed. In a case series from the Hammersmith Hospital, instead, with highly trained laparoscopic surgeon, the conversion rate to open surgery in 191 women undergoing laparoscopic hysterectomy plus BSO plus lymphadenectomy was around 1%. So this last study, UK study, was a study that was conducted with very, very well-trained laparoscopic surgeons. And so it was a little bit less standardized than the one that I mentioned before. And then there is our experience in which at the Royal Infirmary Hospital of Edinburgh, from June 2015 to June 2017, those are data that we published just in January this year. All consecutive patients were considered for the study, and all patients were treated by the same surgeon. And all the data were absolutely prospectively taken. And at the end, we decided to try to find what was the fragility of the patient, what was the a way to study what were the characteristic of the patient that were at high risk of having comorbidities and also complication from the surgery that we were doing on them. So 11 variables were assessed, and those were diabetes, functional status of index with higher than 2, equal or higher than 2, BPCO, pneumonia, congestive heart disease, myocardial infarction, percutaneous coronary intervention and or stenting and or angina, hypertension, peripheral vascular disease or an ischemic rest pain, impaired sensorium, transient ischemic attack or a CVA, or any other deficit from a cerebrovascular accident. Those patients were deemed more fragile than others, and this was evaluated using a modified fragility index, and I will explain you afterwards how this was decided. So in this series that we had, 100 patients were surgically treated for endometrial cancer with an elevated fragility index and more than 3, in which more than 3 comorbidities were existing. This was related to a statistically higher access rate to HDU, to intensive care unit or to high dependency unit. That was 33% versus 6.6% in those that had no prior fragility index more than 3. Overall, 31 patients of those that we operated, which means around 31%, had postoperative complication. Most of these complications were absolutely manageable, and only few of them were serious. But at the end, the overall stay of the patient was always affected by this. We had no death, of course, but at multivariate analysis, being subjected to laparotomy and having a fragility index of more than 3 were independent predictors of overall complications. Those complications were according to the WHO system. Smoke more than 20 cigarettes a day and a fragility index of more than 3 were the only independent predictors of severe complications. So the overall complication was affected by being subjected to laparotomy and having a lot of comorbidities, and smoking more than 20 cigarettes were the only independent predictors of severe complication. What this means that not always when a patient has a comorbidity, she is not deemable or candidate for a radical surgery. We have to think that today we are able to study the perioperative period on the ground, on the table, and we can absolutely be able to perform a surgery that will not affect the overall capacity of the patient and will be a safe. This will be a safe procedure. So we have this kind of data are showing us that this is a feasible surgery, and people, persons affected by endometrial cancer should not be jeopardized if they have comorbidities or factor of risk, and this being also the age. As you can see here, this is the table coming from the work, the American paper, Lab 2. This shows that we have cause of death in patient from 60 to more than 80 years old are significantly present, but at the same time they are not reaching a number on 500 total patients, a number which is as much worrying as we would imagine. So the BGCS, which is the British Gynecological Cancer Society, came out with some guidelines on this subject, and they decided not to mention anymore the age or the obesity or any comorbidity, but they call these patients like unfit for standard treatment. Okay, and in this patient, in 2018, BGCS was advising for a vaginal hysterectomy, which could offer a good palliation in women with non-endometrioid cancer who are less likely to respond to alternative management such as progestogen. It would consider giving a standard treatment like hysterectomy and bilateral salpingo-oophorectomy under general anesthesia in those patients who had morbid obesity or intercurrent medical condition, and giving radiotherapy on the pelvis or a conservative management in these cases. So you can see that this kind of treatment is a little bit seen as a little bit of over-treatment, even by the authorities. And instead, our results demonstrated that we can do a surgery which was successful with no severe morbidities in terms of life-threatening morbidities in patients that had really a status of comorbidities that was quite elevated. So the ASCO panel came out also with an educational book on this, saying that older patients who are very common in the population affected by endometrial cancer should be allowed to have the treatment as much as standard as possible, with older women being more likely to be diagnosed with poor prognosis disease and more likely to die of disease compared with younger patients. And older patients with endometrial cancer less likely to be offered surgical therapy, retroperitoneal node dissection, and adjuvant therapy. And the advice was that involving geriatrician and or performing comprehensive geriatric assessment may aid in treatment decision making and may aid in getting those patients to receive the best treatment possible. We have to remind that there are several situations that are have been also associated with the treatment of the patient affected by obesity. One of these is linked to the role of apronectectomy. What is this? This is what we call also lipectomy, and this seems to be seen as a sort of panacea in treating surgically patients that are morbidly obese. It consists in cutting out the panniculus in its apron-like area, and by this allowing an access which is a little bit easier to the surgeon. Now, in our experience instead, we had a better exposure and a better control of the disease by using, instead of laparoscopy, where the laparoscopy was not feasible, where we converted, and we had a conversion rate around 2.7%, and those patients that we converted on were morbidly obese, were really affected by comorbidities and morbidly obese. Those patients that we decided to treat with a laparotomy were not treated with longitudinal vertical xiphopubic laparotomy. We decided instead to use a mini laparotomic approach, a Kastner incision, which means that we did a small incision. Small must be also understood. It's not really a 2 centimeter mini laparotomy. It is 10, 12, sometimes 15 centimeter laparotomy, which is suprapubic transverse with an opening of the fascia, which is longitudinal to the umbilical scar. This would allow to reach the pelvis in total safety using the retractors to avoid the closure of the surgical field by the bowel, and would allow to have the surgery performed in quite an easy way. And we decided to do this because when we started doing also a lot of apronectomy, which lipectomies, we had several cases of in those patients that were really affected by comorbidities like vascularization defect. We had this kind of situation, like big necrosis, which were very difficult to control and also very difficult to treat, and which would give us a situation of hospital stay for more than 20, 30, sometimes 46 days. So we decided to introduce, instead of a very minimally accessed surgical step like laparoscopy, something at a minor level of minimal access, but not at the level of the longitudinal vertical opening of the abdomen, which was really difficult to control in patients with problems of vascularization. So we came back at this with quite a surprise, and for this reason, we decided that all other cases from now on are going to be treated in this way. This is, I think, the main understanding of our experience with this patient, which means that we have to do the least possible. In conclusion, I would like to say that obesity alone should not compromise the treatment of endometrial cancer. On the other side, older patients should not be denied treatment based on the age alone. And the introduction of a frailty index, like the one that we introduced, is an important predictor of overall and severe complications in patients treated for endometrial cancer, and could be a useful tool for helping clinicians in the perioperative management. Now, of course, this must be done by in appropriate settings with experienced surgeons using appropriate techniques. But at the end, this is the main lesson that we can bring home. It is that patients with frailty of their body and with fragility overall due to their comorbidities should not be denied access to the best care possible. Thank you.
Thank you so much, Prof. Mario, for this interesting and very nice presentation about the advanced management of the endometrial cancer. Really, I have some question you are answering in the last conclusion regarding the obesity, the morbid obesity. It is interfere with the management of the for the endometrial cancer, which is doesn't mean any matter. We can manage the patient actually. So if any one of the audience have a question, or Dr. Ayman or Dr. Mustafa, you can ask, please.
I just would like to say thank you so much, Professor, for the really thorough and interesting talk, because I did learn few new terminology today, which I'm glad, because every day we should learn something new. So we have learned something new today from your talk, Professor. And this one is the fragility index, for example, and how to have a holistic approach when you are managing a case with cancer. Not only a case of cancer, I believe that when we are treating a case or taking a case for surgery, we should have the holistic approach to improve the outcome of this surgery. Um, I'm not surprised when, Prof, when you said that the obesity in Scotland is getting higher, and in UK and in France as well. And I don't know if you have lived in Scotland long enough to know that the unhealthy habit is behind that. Do you know that they are frying the Mars chocolate bars? So it
Yeah,
is,
I know.
yeah, it is.
Unfortunately, I know.
So yes, so this is one of the reasons for the high body mass index plus alcohol.
Yes.
But I would like here to say, you kindly mentioned that 10% of endometrial cancer can be found even before the age of the menopause, which is very good point you kindly raised, because this will make me ask you 2 or 3 questions, if you don't mind.
Absolutely.
The first one is, if you have a patient 57 years old and she's still having regular menstrual cycle, would you investigate this woman as a postmenopausal bleeding? This is the
Of
first
course.
question.
This is the first question, and I answer you. All abnormal bleeding are investigated and should be investigated. So, what means that? It means that a woman that is 57-year-old could also have a very normal situation of perimenopausal cycle, which is continuing. And this must be raised as a normal situation. But at the same time, she could be harboring a tumor. And this is true also for women before that age, when they are 42 and they have abnormal bleeding, which is very long, heavy period. You should always try to understand if this is something which is harboring something else. I think the first step in all these women is always an ultrasound. Transvaginal ultrasound will allow us to have a good vision of the endometrium. And at the same time, we use very much here in France and also in UK, we use cytology. We use the PIPEL cytology, which is something that allows us to have an immediate understanding if something's wrong there, okay? And it has a specificity of 96%. So it is something that we can use with quite a good reliability.
Okay, that's very nice of you. The other thing is, if you have a woman who is asymptomatic, she has got no abnormal bleeding whatsoever, and she's complaining of loin pain, and while we are doing ultrasound for her, accidentally we discovered that the endometrial thickness is 10 millimeter while she is 52 years old. Would you investigate her?
I would investigate her outside of her abnormal situation in all cases. What means that? It means that I would do an hysteroscopy to understand if this abnormal endometrium And I think that you are describing an endometrium which is post-menstrual in terms of because she's bleeding. Okay.
She's not bleeding.
She's
No.
not bleeding. Very
No,
good.
no.
So in all case, you decide she's still having her normal cycle gone. Okay.
Post-menopause, asymptomatic.
Okay, very good. But she has pain, and you decided to do a transvaginal ultrasound to understand what's going on. It could be a mass, it could be something else. You find this 10 millimeters, which are more than 4 millimeters. And at this age, more than 4 millimeters means that you have a suspicion. This can be a suspicion of atypical hyperplasia, can be a suspicion of polypoid. You have to understand also that sometimes we have a closure of a stenosis of the canal, so that we don't have any bleeding inside.
Sure.
Okay, and for this reason, the pain can be due to the fact that the endometrium is a little bit swelling inside, and she has this pain. So in all cases, I think that a mandatory step, anytime that you find, I would say, an abnormal endometrium, either because of the period related to the period, or because of a postmenopausal status, should allow you, of course, clinically, being this said that you are the one that decides if this is raising or not your suspicion, of course. And in all cases, I think that when you have more than 4 millimeters, as a rule, you should go for more investigation.
Thank you so much, Professor Mario. Thank you so much. That's very nice of you.
Thank you.
There is a question from one of the audiences, the successful rate of surgery and expected lifespan post-surgery.
Sorry, I didn't get the last word.
The lifespan post-surgery.
Lifespan. Okay, so I would say that maybe we should say that if we refer to patients that have good surgical margins after the surgery and had a surgery done for a low risk endometrial cancer, endometrioid in type, I would say that the overall survival is very high, very, very high. I would say that it's more than 86, 87% at 5 years. And this because, of course, we are talking here in a fragile setting, and the fragile setting has comorbidities which cannot allow us to be so optimistic in terms of patient reaching a very long span of life. I would say that I had this kind of situation in which we had very, very good surgery, very successful situation in terms of surgical margins, but the patient died 2 years later because of a cardiovascular injury or something like that. So it is something that we have to keep in mind. We are operating on patients that are in such a situation, a clinical situation, that their lifespan can be a little bit shorter than what expected. But let's say that if everything goes well and you have a successful surgery, you would expect the lifespan exception for all the other comorbidities to be quite high. Now, there is also the high-grade cancer. The high-grade cancer is a little bit different because here you can have surprise. It's most of the time when we operate on patients with high-grade cancer, we can have hidden metastases in the pelvic lymph nodes. We can have hidden metastases in the lumbo-aortic area, and this changed completely the story of the patient. While a metastasis on the vaginal cuff, which is that part that we cut once we do this hysterectomy, and on which we can have some seedings of tumor, which will harbor and that we can treat in a prophylactic way with brachytherapy to reduce the risk of a metastasis. Nothing can be done if the tumor has already reached the lymph nodes. In that case, we have to do extended field radiotherapy to the whole abdomen, and they'll allow us maybe to control a little bit this local regional disease, but nothing will guarantee us that the tumor has not already reached the liver with micrometastasis or any other site above that. So I would say that in the second case, when we have a high-grade disease, the lifespan cannot be always respected in terms of expectation. I would say that we calculate that from case to case, depending on the risk, the risk of factors.
Okay.
Okay, Dr. Mario, I'd like to ask you one question, please, if you may.
Yeah.
I'd like to know what is the rule of lymphadenectomy as regards hysterectomy for endometrial cancer. Is it crucial, that the new modulators for radiotherapy and chemotherapy, does it really decrease the need for extensive lymphadenectomy for those patients, or is it the same?
Well, at the state of the art at the moment, I would say pelvic lymphadenectomy has the crucial role in endometrial cancer. When we talk about hysterectomy plus bilateral salpingo-oophorectomy for G2, G3 cancers with a volume of less than 2 centimeters on the MRI, being more or less than 50% involvement of the myometrium, in all cases, pelvic lymphadenectomy has demonstrated the capacity to control the disease. And radiotherapy given to those feeds will sterilize the situation at a point that I would say we have survival respected in terms of total expected lifespan. So the role of lymphadenectomy is, from one side, staging, from one side is also treating, because this is a disease that spread through several, not only the hematogenous, but also the lymphatic. And for this reason, it is a disease that must be addressed with lymphadenectomy. Now, the role of new drugs, the modulated treatments, is a role that has still the big advantage. It is administrable after the treatment, so it is something that can add treatment to the treatment. But as always, we have to think about that the summarization, the sum of the treatment to the have to be quite the consequence are acceptable for the patient. Now, if we calculate this, of course, very important nowadays, more and more applying
Okay, Dr. Mario, there is another question. May I ask you from the audience?
Of the node, reduce overall toxicity. Yes.
One of the audience has a question. One of the audience has another question for you. Can I ask you that question, please?
I can't hear you.
One of the audience has got one question, one interesting question. Can I ask you that one, please, again?
Sorry, I can't.
I have got one question from one of the audience.
Okay.
Yeah. It says like, did you see cancer as a possibility reported by forensics and medical police?
Dr. Mustafa?
Yes, do you hear me? Hello? Hello, do you hear me now?
Yes, I
Okay.
can.
Okay, he's asking that, did you see cancer as a possibility reported by forensics and medical police to learn to care as a symbol the COVID-19 pandemic problematics? So you got the question, sir.
I think the question is not clear from the beginning. If she can asking again this.
It's not clear, yes, is it?
It's not clear. I can't understand it actually.
Even me, I tried.
Yes, it is in the WhatsApp, but I don't get it too. I think that he's telling you that have you got any forensics as regarding this endometrial cancer issues?
I'm sorry, I couldn't get it. I couldn't.
Yeah.
Me neither.
Repeat this question again.
Me too. I just read it.
Yes.
So I don't understand if I cannot understand if the question is related to the fact that a cause of this tumor could be related to something else. This is the question.
I don't get it even. It's just a question from the audience, and I told you that.
Okay, thank you.
There is another one. She asking if 55-year-old with postmenopausal bleeding, it is endometrial cancer, or there is another causes for the postmenopausal bleeding.
Any postmenopausal bleeding is very suspicious. Now, to understand if a postmenopausal bleeding is a bleeding from the uterus, you need ultrasound at least. Or you can see from your inspection, examination, that the bleeding is occurring from the cervix. Okay. Now, the big problem is that sometimes the first sign of endometrial cancer is a very, very small drop of blood. It's not a big bleeding. It's not something heavy. Now, this can occur also because of atrophy of the vagina due to mucosal hypoestrogenism. So it's very important that any bleeding being reported to the gynecologist and any bleeding being assessed by a gynecologist with a visual exam and an ultrasound, so that she can understand where this bleeding is coming from and why it is coming from. Then after, we can do whatever to understand exactly what this means, because there are also a lot of benign situations in which you have bleeding, like polyps, like situation of endometrial atrophy. But we have to remember also that there are a lot of drugs that can give bleeding. And so it's very important to report any bleeding to the gynecologist, and the gynecologist being able to understand exactly where this comes from and why.
And Professor, if you would like to allow me to put on my urogynecology hat, I can say when we are facing a complaint of postmenopausal bleeding, initially we do thorough pelvic examination and vaginal examination, and quite percentage of them, the old age one, would have either urethral caruncle or prolapse, and these are bleeding. This is a very benign condition, but we need to keep it in mind, so otherwise it might be missed.
Yeah, we have to. I mean, you're absolutely right, and I think that your point is I would say more frequent than what I'm saying. I am saying everything from my point of view, which is the point of view of one that sees only cancers every day. So I see the word like affected by cancer, but I have to remember, in fact, that 95% of time it's not.
Very true, sir. Very true, sir. Very true.
Another question come from Dr. Khalid. He's saying that when you have got big tumors, okay, do you prefer to have neoadjuvant radiotherapy before the surgery or no?
We are talking about endometrial cancer, and there is no role for neoadjuvant radiotherapy anymore in the world. This was done for hemostatic reasons, sometimes in the area of heroic area. But today we do the mainstay is surgical assessment and surgery, and this is the staging, because the staging of endometrial cancer is not like the staging of cervical cancer. Cervical cancer has a staging which is more, it's a bimodal, clinical, instrumental, and surgical. Instead, the staging of endometrial cancer is fundamentally surgical. Now, today we have also MRI, which gives us a lot of new insights in what is the disease like, but everything comes from the pathology report. So we need to give the pathologic piece to have the final diagnosis, and from now on, going on with the treatment.
There is another question. If normal lymph node by radiology study, even by MRI, less than 50%, do you proceed for lymph node sampling or only the hysterectomy?
Sorry, but it was very difficult to understand. But you were so. Can you just summarize what is the question?
If the study for the endometrial cancer is less than 50%, and the lymph node is normal during the study by the MRI, you will proceed for the lymph node extraction or only the hysterectomy?
So you have several points of view on this, but you have to remind one thing. You don't have only MRI, okay? You have ultrasound, which gives you an insight. The reason why you are doing a lymph node is either a G2, G3, or an M, which is the myometrium status, more than 50%, okay? If you have one of these conditions, you're allowed to do pelvic lymphadenectomy. Otherwise, if you are not feeling comfortable with doing pelvic lymphadenectomy, nobody is asking to do this always. You can just do the surgery, the standard surgery, and then you decide if reoperate the patient and doing a sentinel node, reoperate the patient and doing a systematic, complete radical pelvic and or aortic lymphadenectomy, or doing nothing and address the patient to the radiotherapy. You have still several ways. The important is that you have studied the patient in the most comprehensive way, so that you have all the information once the pathology report is there. You have another biological factor, which is very important, is the lymphovascular space invasion that will be given just at the end of the pathologic report. So when this happens, you may have a very normal G1 low-grade tumor that you're operating with the simplest of the total laparoscopic hysterectomy and bilateral salpingo-oophorectomy, and then after 15 days you have the report that shows you this situation. Then normally we are going to discuss the case at the MDT with radiologists, with radiotherapists, with anyone is involved in this kind of treatment, and we're going to decide if bring back the patient on the table to do pelvic lymphadenectomy or doing nothing and doing pelvic radiotherapy. So, I mean, what I showed is in my slides was the treatment that we normally do here in France and before that in UK. But anyone can add to this his views and use the most compatible treatment that he or she has according to what is available in his center, okay, of treatment or not. Of course, the standard sometimes is not exactly the excellence. It can't be always this. I mean, I am faced with this every day. I have to accept the situation of what I have under. Sometimes the patient is not well studied, arrives with some kind of flows in, and we have to adapt a little bit. But the concept of staging, the concept of accepted treatment, and the peer-reviewed treatment that you can have doing an MDT, all this must stay because it allows us to guarantee the best treatment to the patient.
Dr. Nawal, I have a question. Professor, I will stick to the same question for that lady who have no lymph node on the radiology study, and the MRI showed cancer or invasion of less than 50% of the myometrium. Do you do routinely peritoneal wash for cytology?
Well, the cytology has lost its power of, it's no more so much important, but it's reported in the FIGO staging, so you have to do it.
All right.
Just because it is reported in the FIGO staging, just for that.
Thank you. Thank you.
There is one of the audience, she's from the Philippines, she's asking about her mother. She's diagnosed with endometrial cancer stage 4 after surgery. She asked if she still undergo surgery through when she has her age over 60-year-old or through chemotherapy.
So this patient has a stage 4 disease.
Yes.
Stage 4 disease is inoperable. Now, I don't understand if she's referring to a patient that has been already treated and then metastasized after she had an advancing disease and loss of control of the disease after the surgery, and then she had what is a metastasis, and for this reason they explain her with this term of 4th stage. I don't know if this is the problem, but if she had a 4th stage disease on MRI and CT scan, she should not be operated. She should go for either palliation or best treatment care.
Okay. The same question, the postmenopausal bleeding, if not a cancer, there is another reason. There is, I think, a lot of...
I think that this is summarized by what we said before. You can have 95% as my colleagues said before. I mean, you can have 95% reason not to have a cancer and 5% reason to have a cancer. This allows you to be absolutely optimistic. My point of view is that any bleeding must be ascertained. And once you have the assurance and the reliability of an exam or an investigation, or I would say also cytology, then you're absolutely fine and can go on thinking that you don't have anything and you're right. But otherwise, I would say that it's any kind of bleeding should be assessed by a pelvic exam by a certified gynecologist that will absolutely know what to do and what to decide for this.
Exactly. I think we finished the most of the questions, and I would thank Prof. Mario for this very interesting and very nice presentation and the answering of our question. And also thanks all our other doctors, Dr. Mustafa and Dr. Ayman, and our participant audience attend this webinar, and we hope we will meet you again, Dr. Mario, and see you soon, inshallah, in one of our branches.
In Riyadh.
Thank you.
Thank you so much.
I'm looking forward. It was very
Thank
nice
so
to
much,
have you.
sir. Thank you.
And thank you for
so much.
having me. Thank you. It was really, really warm, and thank you.
Thank you. Keep
Thank
safe.
you, Timur. Thank you.
Thank you.
And
Bye-bye.
regarding
Keep safe, every one of us.
Yes, thank you. Regarding the lecture, if there is anyone interesting to listen again, it is, I think, in YouTube under the Smart Podium page. So you can see it again there. Thank you all, and see you soon, inshallah, in other webinar.
Thank you, Dr. Arwal. Thank you.
Welcome. Thank you. See you soon.
Okay.
Bye-bye.
Bye-bye. Bye-bye. Thank
Bye-bye.
you. Bye-bye.
Bye-bye, Dr.
Bye-bye.
Mustafa. Bye-bye.
See you
Bye-bye.
next month. Bye-bye. Bye-bye.
Okay, take care. Bye-bye.
Bye-bye.
Thank you, everyone.
Thanks.
Goodbye.